Hi everyone, my name is Anni Liu and currently I'm a second-year medical student at the University of South Florida Morsani College of Medicine. Today I'll be presenting a systematic review called Educational Intervention Studies aimed at increasing colorectal cancer screening among men and women in rural communities. So in the United States, CRC is still one of the leading causes of cancer-related deaths, and this is despite the spectrum of screening modalities that are currently available for CRC, such as colonoscopy and fecal immunochemical test, which is also known as FIT. Although we do see a decline in the incidence of colorectal cancer, we notice that health disparities still persist in rural areas, and this disparity is likely caused by factors such as geographical isolation, lower socioeconomic status, and limited access to healthcare. So the goal of this review is really to examine the current landscape of educational interventions that are designed to address this disparity in rural populations. For the method, we followed the standard PRISMA for a systematic review. I also listed the inclusion criteria here for your reference. So here's a PRISMA diagram. We started off with a total of 822 studies. After the screening process, 26 articles met the inclusion criteria and were included in the review. Out of the 26 studies, 20 of them were conducted in rural populations, and 8 of these focused specifically on colorectal cancer, as you can see here at the bottom in boxes highlighted in orange. There were 3 randomized controlled trial studies, and 2 of them were statistically significant, which I highlighted here in red. For the Levy 2013 study, it had 3 arms, and only the second and third arm, which used male education along with FIT, as well as a follow-up phone call, showed significance. For the Preston 2018 study, it used community educational presentation as its intervention, and it had 2 arms. The community-focused arm used presentation that was driven by personal stories and individual assessments. On the other hand, the general focus arm presented information concerning the national statistics and general information on CRC. The third randomized control trial study used the method of follow-up phone calls, one arm being the personalized phone call and the other being an automated phone call. Now, moving on to the non-randomized control studies, only one of these studies showed a statistically significant improvement in CRC screening, and this was the Geller 2006 article. The study focused on a rural community in Hawaii where residents had limited access to cancer screening. The intervention was a 30-minute visit with a physician during a community celebration that included culturally relevant cancer education and brochures, Hawaiian music, and games for children. As you can see, the intervention was able to significantly increase the screening rate for both men and women in this community. The other non-RCT study either did not have statistically significant results or they simply just did not report it. I also just wanted to highlight that only 1 out of the 8 total studies listed here was conducted at the provider level, and the rest intervened at the patient level. So just to briefly summarize the results, 3 out of the 8 studies has statistically significant finding, and they use intervention, which I just mentioned. The rest of the studies, majority being non-RCT, use interventions such as telephone counseling, telephone follow-ups, and physician education. Stool-based test was by far the most common screening modalities used in these studies. However, other screening methods were also used as well. One of the current gaps in literature is to find ways to improve the annual stool-based test screening adherence, since, for example, the FIT is recommended to be done once a year, and it seemed to be one of the most popular screening method in the 8 research studies. Secondly, we noticed that there's a lack of research that design intervention at levels other than that of the patient. Therefore, a possible future direction is to explore multi-level interventions. And in conclusion, we found that cancer education does indeed play an important role in promoting colorectal cancer screening in rural populations. And in order to solve these disparity that's still present in these communities, we believe that it is essential that we keep these interventions in mind for the future, particularly when making CRC guidelines and possibly when incorporating CRC screening into the rural communities. Here are my acknowledgements, and this concludes my presentation. Thank you so much for listening.